Similar to the upper limb examination, the signs in the lower limb examination are reliable if you use the right technique. Many candidates use suboptimal technique and hence struggle to pick up the right signs. We will now demonstrate the lower limb examination. If you have not had a look at the upper limb examination yet, please have a look at that first. We will not repeat the tips demonstrated in that examination.
Good morning, sir.
Morning.
I'm Dr. Marianne. Thank you for letting me examine you. Could you help me to roll up your pants a bit more in your seats? Thanks. Alright. Could you help me to raise your feet this way? Very good. And
This is an important step, testing for foot drop from the foot of the bed. If you identify that there is a foot drop, you will want to do additional steps during the power testing, such as testing for foot inversion and eversion, as well as testing for hip abduction to help you to localize the lesion.
right, relax. Okay. Just have a closer look. Right. Okay, I'm going to be moving your legs, so just completely relax, okay?
Sure.
Okay, and I'll be lifting your legs and catching your legs, so just relax too.
When performing Clonus, flex the knee joint and the ankle joint slightly. Perform Clonus in this position. So I'm just going to test for your leg. Just relax completely. Okay. Up to 3 beats of Clonus is normal.
Now I'll be using the blunt end of the stick and just scratching it against the bottom of your foot.
Sure.
Please let me know if it's painful and I'll stop. Okay, good. Thank you. Okay. Now I'll be checking your reflexes. Just relax and put all your weight on me, okay?
Sure.
Okay, reverse, yes.
Doing this is important. Supporting the weight of the leg with your hand helps to remove the muscle tone from the leg so that you improve your chance of getting a reflex.
Okay, again, relax. Put all your weight on me. Okay. Right. Okay.
If the patient is hyporeflexic, the next step will be to do a reinforcement maneuver. Ask the patient to pull with his upper limbs. So I'm just going to count to 3. On the count of 3, please pull. Okay. See, on the count of 3, please pull. 1, 2, 3. 1, 2, 3. Alright, thank you very much, sir. When you do this, it's important to get the timing of your strike and the counting correct so that the patient pulls just as you strike.
Okay, so now I'm going to see how strong you are. Please raise your right leg straight like this. So let me push you down.
Yep.
The other leg. And now push down on my hand.
Yep.
Very good. Good. Okay, I'm going to bend your leg. Kick out against me.
Yep.
Good. And the other leg. Kick out against me. And pull in. And pull in. Okay. Put your feet up like that. Don't let me push you down. And step down my hand. Step down my hand. Big toe push up against me. Same for the other step. And push down. Push down. Okay.
The lower limb muscles are anti-gravity muscles and they are normally very strong. You should not be able to overcome even ankle dorsiflexion with your hand. So do you mind to pull up towards me? This you should not be able to overcome with your upper leg. If you identify that there is a foot drop, you will want to check for foot inversion and eversion as well as hip abduction. To test for hip abduction, you ask the patient to turn. So remind to turn to your left. lift up your leg this way and test it anti-gravity in this motion. Thank you very much, sir. Please relax. If there's any doubt about the patient's hip extension, you want to ask the patient to turn prone and test for extension against gravity.
Okay, so now I'm going to test how well you can feel. This is the sharp end of the stick. Are you able to feel?
Yep.
Good. So now can you please close your eyes and tell me whether the points on your legs feel the same or reduced?
Yep.
Okay.
The same. Same. The same. Yep, the same. The same. Yep, the same. 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 Yep, same.
Okay, good. Now open your eyes again.
As you test for pinprick sensation, do ensure that you know the root values of the points in which you test. So for instance, this will be L2, L3, L4, L5, and S1. If you have a strong suspicion that this is a case of peripheral neuropathy, for instance, if it is the lower motor neuron pattern of weakness, you've seen the Charcot's foot, you have seen distal wasting, you've seen clubbing of the toes on inspection, then instead of testing sensation in a dermatomal manner, you may wish to test from distally to proximally in a glove or stockings manner. So do you mind to close your eyes, please? Yes. I'm going to go from the bottom up with the sharp end of a stick.
Yep.
The moment you can feel it and it is sharp, let me know.
Okay. Sure.
Close your eyes, please.
Yep, I can feel it now.
Is it sharp now?
Yes.
All right.
Sharp. Yep, I can feel it now.
Okay.
Okay, so I'm going to check how well I can feel vibration now. Can you feel this?
Yep.
Okay, good. Close your eyes and tell me when the vibration feeling stops.
Okay. Yep, I can feel it. And it stopped. Yep, I can feel it. Yeah, it stopped.
If there is a reduced vibration sense, the next thing to do will be to move up to the next bony prominence. So after testing at this location, you will want to test along the medial or lateral malleolus. If you don't get a positive vibrations feel here, test against the knee cap and subsequently on the anterior superior iliac spine.
Okay, now I'm going to check how well you can feel positions. So have a look down here. Okay, so this will be up.
Yep.
This will be down. Close your eyes and tell me which position, okay?
Yep. Down. Up. Up.
Good. The other side.
Down. Down. Up.
Okay. Lastly, I want to check how I can coordinate. So I'm going to show you the positions.
Sure.
This will be 1. This will be 2.
Yep.
3 and 4. Would you do that for me?
Sure.
And the other side? Excellent. Okay. May I trouble you to show me how you walk?
Sure.
Thank you.
Gait is an important part of the lower limb examination, and we typically advise doing gait at the end of your examination. Particularly if your patient is frail or elderly, getting the patient to come down from the gait and walk may take an inordinate amount of time. Additionally, gait is not straightforward to describe for many candidates, and it would be good to have a sense of what the pathology is first before looking at the patient's gait. In some instances, if the patient is young, or if you strongly suspect a particular diagnosis, such as Parkinsonism or bilateral cerebellar signs, then doing the gait first may be to your advantage. As you examine for gait, do not forget to note if the patient has any walking aids at the bedside. And if you are concerned that the patient appears frail or too weak to do the gait, ask the examiner first whether you may proceed with the gait examination, and many times the examiner will tell you that it is not necessary. After completing the lower limb examinations, you may, in many stations, have to examine the upper limbs or the cranial nerve to localize the lesion. If you identify, for instance, bilateral cerebellar signs in the lower limbs, you will want to demonstrate cerebellar signs in the upper limbs as well as in the cranial nerves. If you identify bilateral spastic paraparesis, you want to localize the level of the lesion by examining the upper limbs, as well as identifying a sensory level by checking the sensation along the abdominal wall. This is the lower limb examination.